Welcome to everybody. This is the first 2021 meeting for the Jacksonville Chamber Health Council. So I want to welcome all of you, and those of you that have not joined us before, welcome. Those of you that have joined us before, welcome back. We made it past 2020, yay. I know we talked, seemed like every time we met, everybody's saying, oh, I hope 2021 hurry up and gets done. We make it through. We made it through. I knew we would. But welcome to 2021. So, Amanda, are you controlling the slides, or do I have control? Yep. So if you'll just go on. Our agenda for today is similar to past meetings. We've got a couple announcements, both pertinent to the Health Council, and then some chamber announcements as well. We've got a great presentation on deck from Dr. Pulido. And just looking through his slides, it's going to be very informative, and really looking forward to that. We will have some networking toward the end of the meeting, and so just kind of the format for that. If you haven't joined us, once the keynote presentation is over, we will automatically be kind of sent into breakout rooms, and there'll be probably 3 to 4 people in each breakout session. And we'll have probably about 10 minutes or so. So just, be cognizant of the time. Take 1 to 2 minutes to introduce yourselves. Tell a little bit about, who you are, what you do, your company that you work for. But again, don't take all the time. Make sure you give everybody ample time to introduce themselves. And then if you do have extra time and want to talk about what you're looking forward to in 2021, or anything fun or exciting that you may have done over the break, then be happy to do that. Make sure that you exchange contact information so that you can follow up with each other afterward, and use that time to introduce yourself and meet new people. And then finally, we'll come back. There will be an automatic, I think like with a minute left, you'll get a notification that the session's almost over. We'll come back at the end, and just a reminder of our meeting coming up in February. Okay, next slide, Amanda. So I don't think I actually introduced myself. So I'm Jason Lafser. I am the 2021 president for the Health Council. You'll see the listing on here of our board of directors. These are all the people that make things happen behind the scenes. So I wanted to say a special thank you to all of these people. And I know Josh Jolly is on. I wanted to give a special shout out to him. He was our president for 2020. And I'm sure, like everybody on the call, for the Health Council, 2020 was an unusual year. We started the year kind of business as usual. We were meeting at Deerwood in person for our normal monthly luncheons, and then around March, like everybody else, we kind of said, whoa, what do we got to do? What are we going to do? Do we shift to virtual meetings? Do we not meet at all? Do we keep meeting? And so I just really want to thank Josh for his leadership over the past year. Him and some of the other prior board members are the ones that got myself involved with the Health Council. And I just want to thank him for his leadership, not only as president over the last year, but he's served many roles on the board: vice president, president, programs director, you name it. He's kind of done it. So thank you, Josh, for your leadership. And want to thank the rest of the board members. Also want to bring to everybody's attention, if you are interested in getting more involved with the Health Council, these are your points of contact. So obviously, feel free to reach out to me, but also feel free to reach out to anybody that is on this slide, and we can certainly get you more information. It doesn't have to be, at the level of being on the board of directors. We have a lot of committees that you can also get involved with. And, certainly if you're interested in getting involved, we can find things that you can do to help us. So please definitely reach out, and thank you to all these board of directors. Next slide. I want to take a minute, obviously, to thank our sponsors, Florida Blue and Nemours. They've been great to the Health Council, not only the community in general, but to the Health Council specifically. And, we really are appreciative of them for not only their financial contributions to the council, but also just their overall contributions. Each of these sponsors also has a member that serves on our board of directors. So they're not only giving in a financial sense, but giving of their time and other resources as well. I do want to mention too that we are in the process of developing our 2021 sponsorship package. So if you or your company is interested in being a sponsor of the Health Council, please again reach out to myself or anybody that's on the board of directors. And it's not something, we're looking at different ways that companies can sponsor us, and so it's not something that you have to kind of contribute for the entire year. There are options to be a sponsor for a specific monthly meeting. And so if that's something that maybe fits into your budget better than looking at something for an annual sponsorship, we'd be happy to talk to any of you about that. So I'm thinking probably within the next week or two, we'll finalize that sponsorship package and probably post that on our website. So again, if that is something that you think your company or yourself may be interested in, please reach out to us. Be happy to talk to you. And with that, I'm going to turn it over to Tina Robbins for some JAX chamber announcements.
Thank you, Mr. President.
Thank you.
And welcome and Happy New Year, everyone. I'm so appreciative that you're here. I just want to let you know I'm your Senior Account Manager for the Health Council and also the JAX Chamber. So if you'd like to become more engaged with our chamber or the Health Council, I'd love to assist you. First of all, on January 14th, we are hosting our Beaches Luncheon at the Casa Marina Hotel. It starts at noon, and our keynote speaker will be Karen Mathis, the famous Karen Mathis from the Daily Record. She will be talking about the economy for this year, so it should be quite interesting. Please pre-register online, or you can call Kathy Sutton at our Beaches office at 273-5366. You can find everything on our website as well. And also on February 2nd, we are hosting our Small Business Leader of the Year breakfast. This will take place, it's an annual event, which will take place at the Schultz Center. It begins at 8 a.m. We're usually out of there by 10. Great networking, also a wonderful way to recognize our leaders from each council. So we're very, very excited to be hosting this on February 2nd. The price is $35 per member and also $50 for non-members. So please pre-register. I know they're going to have a cutoff at a certain amount, but we'd love to have you join in. And if you have any questions at all, please feel free to send me a little email or something through my chat, and I'd love to assist you. So Happy New Year once again. And here is our beautiful board member, Ashley Skakowski. Thank you.
All right. Hello and good afternoon, everyone. Happy New Year. Yay. We made it through 2020. Excited to get that behind us. Without further ado, I am so excited to introduce you guys to Juan Danny Pulido, who is a pulmonologist and critical care specialist at Baptist Health. So Dr. Pulido was born and raised right here in Jacksonville, Florida, attended Assumption and Bishop Kenny, later received his undergrad and medical degrees from the, get this, Universidad de Ciencias Medicas, the University of Medical Science in San Jose, Costa Rica. So Dr. Pulido returned to the U.S. to complete his residency and fellowship in pulmonary and critical care at the University of Florida, go Gators. And Dr. Pulido is a board certified in the practice of pulmonary and critical care. He's also trained in advanced bronchoscopy, including endobronchial ultrasound, as well as navigational bronchoscopy. Boy, that is a mouthful, I can tell you that. I've practiced that and it still didn't come out right. So these procedures can help with early detection in lung cancer, which would provide better outcomes for patients. For the past 3 years, Dr. Pulido has been the medical director for Baptist Beaches Intensive Care, North Florida Lung Clinic, and recently took a position as the medical director for Dolphin Point Rehabilitation Center. On a personal note, he and his wife, who is also a doctor, Dr. Paula Salas, love to spend their time in the community where he grew up. He's got 4 children. They love boating, traveling, reading, and volunteering in a variety of sports and scouting events. So Dr. Pulido, we are so excited to have you. And although we are all tired and ready to put COVID behind us, we understand that there's still work to be done. So thank you for being here, and we can't wait to hear what you have to say.
Thank you very much for having me, and thank you for the whole board for this time and opportunity to present to you guys. I'm very excited to show what we've been able to accomplish and see through the research, what we've been doing here at Baptist System, and then also to share some of my experience of what we've unfortunately had to go through in managing patients with COVID. I'll give a little bit of insight of what we recommend not only in the acute care, hospital-based patient care, but also what I've been telling my friends, family members in the community, what to do if you feel like you have COVID or if you've been exposed to COVID, and then what are the other halo effects we've been seeing due to COVID, such as psychological issues and so forth. So with that being said, my presentations are always meant to be informal, just relax. If any time, I know that the slides have a lot of, I've always preferred giving more slide presentations of imagery as opposed to verbiage. So a lot of the slides are going to be more of pictures and showing the description of kind of what happens to our body if we get, unfortunately, COVID. At any time, if it's somewhat confusing or if you have a question, just shoot it out. Be happy to answer it right then and there, as opposed to waiting for all the questions at the end of the slide deck. With that being said, I don't know, I see the pictures of everybody, but I don't see the slide deck. I don't know if we can have the presentation up for view.
So I've made you a co-host, so you can manage the slides, or I have it available if you'd like me to manage them, whatever.
So I need to share my screen?
Yes, sir. I've made you a co-host, so you should be able to do that. Perfect. Thank you, Dr. Pulido.
Okay. Minimize this.
Oh,
Can you see me?
is everybody seeing images? I'm just seeing a white bar.
Yeah, that's what I'm seeing as well.
Give me a second. I apologize. Let me try one last time.
No problem. And if not, I've got it available as well.
There it is.
There we go.
You good?
Yep.
Perfect. Thank you.
And can you see my mouse as I move?
Yes.
Okay. All right, perfect. So with that being said, we'll get started right into it. The slide deck really goes into a little bit of the history of what we've been seeing with mortality overall in the U.S. Then we'll talk a little bit about pathophysiology, which means how the virus affects the body, talk about treatments that we've been providing, and then outcomes and what else can be provided in the community when regards to treatment recommendations for both preventive and treatments at home. This slide right here, it was taken from the CDC. It was about a month old, but the point being here is this is the average mortality for the entire United States when looking at infections due to the lung, whether the infections were bacterial, viral, and now with COVID in the mix. You can see in 2020, the spike in mortality we've had due to pulmonary related diseases and failure from an infective organism. We had a spike a little in 2018. At that time, we were also dealing with viral infections, but this, unfortunately, in 2020 has been something of a crisis. This particular slide, unfortunately, I don't believe came out as I wanted to, but it shows the biphasic wave that we had. Essentially, this is another point of it. In July, for Jacksonville community areas where we had a big wave of patients admitted to the hospital, we were in the range of almost to 150, 160 per system. As you can see, each colored graph under this right lower quadrant of the slide deck is a hospital-based system. This purple is St. Vincent's Riverside, and they unfortunately took the brunt of COVID admissions, required multiple units in their hospital to be COVID designated, and required, as you can imagine, the staff, the equipment, and the safety product of all in the sense of utilization for healthcare work and resources, but have since, fortunately, the numbers did start to go down, but unfortunately, in the past month, we've seen this increase of numbers again. The next system was Shands JAX. Also included in there is going to be Baptist Downtown, Memorial, and then as we go farther down the list are smaller hospital systems, but clearly, as you can see, it was overwhelming to the entire health system here in town, both private and academic, when admitting patients for COVID respiratory failure to the hospital. This slide deck really goes over what we see for COVID in the sense of overall infection rates. The good and the bad with COVID infections, 75% of the patients who get infected with COVID really will have a mild or asymptomatic course. Normal healthy patients, active patients, patients who eat well and live well and have a healthy lifestyle, the majority will have no symptoms to very just mild respiratory like cough, cold, sore throat for a period of 2 to 3 weeks, and it will resolve on its own. Supportive care, Tylenol, hydration, and good rest will help improve that process along quicker. Unfortunately, about 25% of the patients who get COVID will then get admitted to the hospital. The comorbidities that we've been associated with COVID admissions have been diabetes, overweight, cardiovascular disease, and age. Those are definitely the risk factors that we've associated with an increased infective disease state of the lung. And then unfortunately, of those 25% of the patients who get admitted to the hospital, 15% of the patients will be transferred to the ICU for some dreadful diagnosis that's called ARDS, acute respiratory distress syndrome, which essentially means the lungs themselves are becoming so inflamed that the patient cannot oxygenate despite hyperoxygenation with lots of oxygen that we give to the patients. Now, we've gotten better in understanding the process specific to COVID and how it affects the lungs. So treatment strategies have been changing over the few months, but still, unfortunately, the mortality of COVID patients have been averaging around 5 to 6% national-wise when you look at strict death mortality due to COVID. The definition of COVID mortality has changed. When we first started with this back in March and April, any patient who died in the hospital system who had a positive COVID test, we were instructed to label as COVID mortality around July when the spike of COVID admissions occurred and we had more unfortunately related mortality. The health system, the health department was becoming overwhelmed with cases that needed to be reviewed, and they clarified the definition of a COVID death to specify that it was a respiratory failure, acute respiratory failure with COVID as the cause of death, essentially ruling out anybody who came in for other disease states such as cancer or a heart attack, but ended up having COVID for other reasons. Those are the type of patients that we're trying to differentiate from. This is the inflammatory system that we've come to better understand when patients get infected with COVID. When patients initially get infected, there's this early phase of viral replication that occurs. And in this early phase, the patients are going to have either be asymptomatic or have some mild symptoms. And as I said, 75% of these patients, as the virus, eventually the immune system starts to recognize the virus and kills off the virus then will eventually fade out and no longer become a problem to the patient, and they will essentially recover from this process. But unfortunately, as just showed you on the percentage there, 25% of patients will have a second wave of inflammatory reaction and start to develop pulmonary damages of the lung due to the virus. It's this phase that becomes more concerning as we are treating and admitting patients to the hospital, because this phase is where damage of the lung occurs, and this is where we try to become very aggressive on our treatment strategies. So we initially initiate medications that are more anti-inflammatory in nature, but also we are using the famous remdesivir, which is an antiviral therapy to help continue to reduce the viral replication. It's this third phase here as patients become what's called hyperinflamed, and that is the dreaded ARDS, or acute respiratory distress syndrome, that unfortunately progresses so much so that these patients will likely become ventilated on life support. And then once placed on life support, the numbers don't look too well when regards to statistics and prognosis of having a positive outcome. So that is the phase that we're always trying to avoid and to minimize the damage to the lungs. And there's been a variety of treatment strategies now that we're starting to implement regarding anti-inflammatory medications, one being linzulumab, another one being dexamethasone. We're obviously trying to, you've heard of this dreadful cytokine storm, which starts at phase 2 and progresses in these types of patients. So everything that has to do with anti-inflammatory, really, I would say the biggest one that's been the game changer for patients management is really steroids. dexamethasone early in the course to reduce this second wave of inflammation has really shown the best to reduce this progressive disease state of patients. On a side note, we had essentially in July, around any given time in the peak, around 150 to 160 patients admitted through the Baptist system with COVID. And here at Baptist Beaches Hospital, we were down to the last ventilator. We were literally using pediatric ventilators, and we were discussing with our anesthesia colleagues on how to bring over the OR ventilators to use in the ICU. And there was even discussion about doubling up patients on ventilators. So we were exhausting all means possible to try to continue to provide for the community out here at the beach. And I know downtown and South was having the same exact discussions. Interestingly, on this wave we're having now, throughout December and into January, we've seen actually more admissions than we had back in July. But this time they're not as sick, and there's not as many ventilated patients as we had back in July. Currently in the ICU at the beach here, we only have 2 to 3 patients on ventilators due to COVID, despite having higher admissions on COVID now. So we've gotten better in recognizing patients who are progressing. We've gotten better at early strategy therapies to minimize inflammation, but still the virus is out there in the community. It's still spreading. We can't prevent all damages of the lung, but we've definitely getting better to minimizing the critical patients. So this is the basic anatomy. Before we try to explain what happens to the lungs, I think it's always best to understand how the lung's supposed to work on a normal patient. So the basic structure, anatomy of the lungs really begin from the tip of the nose, which is the upper airway passages, nasal passages, oral passages, connects through the pharyngeal passages and into the airway, the tracheal and then bronchial airways, and then the bronchioles keep dividing into what's called terminal bronchioles. At the terminal bronchial level is where you start to get what's called alveolar sacs. If you could think of just basically grapes on a vine, these alveoli sacs are air sacs that oxygen, when inhaled in as air is breathed in through the respiratory system, goes all the way down to these little terminal air sacs. And it's in these air sacs that oxygen diffuses into the bloodstream. The CO2 in the bloodstream diffuses out, and that's what we exhale back out again. So this process happens every single breath. These blood vessels that you can see wrapped around each alveoli is what allows blood to flow around and for this diffusion of oxygen and CO2 to occur at the membrane level. We can actually measure this with a pulmonary function test that we do in our office. Pulmonary function test breaks it down to 3 categories. Spirometry, which is the measurement of flow, tells us how well does air simply move in and out of your airways. Lung capacity, which is a measurement of how much volume your lung can take in, essentially like balloons. They should expand to the predicted body weight depending on your age and height. And then the last being diffusion capacity, we can actually measure how well oxygen diffuses through the blood and how well the CO2 diffuses out to determine the functionality or how well this membrane is actually working. So this is a normal process of how lungs are supposed to work. This, on the other hand, is an abnormal. So this being the alveoli sac that I was just referring to, this split in half. This side of the slide deck is really normal alveoli with a thin membrane, a capillary blood flow that goes around it. As oxygen molecules come down as we're breathing, oxygen diffuses through through this membrane, and then is picked up through a red blood cell and carried on through throughout the rest of the body. In the damaged alveoli, due to whichever the inflammatory cascade is caused by, whether it's COVID vaccine or COVID virus, bacterial pneumonia, fungal pneumonia, influenza, this process is essentially repeated for any type of infection in the lungs. Once you get an infection, the same as you would get infection of the skin and break out in cellulitis and your skin turns red and inflamed and swollen, the exact same process happens in the lungs. Through a variety of mediators that communicates within the system, once the system is activated, think of the inflammatory system as the military defense for our country. Once some threat is initiated to our country, the defense military goes into action through a variety of different pathways via Navy, Army, Marines, Coast Guard, whatever methods needed to protect the body. And this is the same process in our body, which we have T cells, B cells, or killing cells, and then a variety of mediators that are communicating within each other to make sure that they're all attacking at the same time. So unfortunately, like a battle and war in any neutral area where two countries are fighting, once the war is done and both countries retract back to their normal homes, the battle of where the town took place is going to be destroyed and devastated. That's essentially what happens in the alveolar process. The body immune system is battling against the enemy being COVID, and the unfortunate neutral area that's being damaged is the alveolar membrane. So this process will carry on so much so that this whole alveoli essentially becomes useless or unfunctional and damaged and permanently scarred down. This membrane in between becomes thickened. So oxygen, as patients are trying to breathe, oxygen comes down, but the oxygen molecules, once it reaches this pink area, is really fluid building up in the alveoli. Oxygen molecules cannot make it down to the red blood cells that need to be picked up in the capillary. That's why patients then become so hypoxic, which means low oxygen levels in the bloodstream. And to add more injury to this concept, the virus itself, due to the inflammation, has been shown to damage the blood vessels themselves, causing increased risk of blood clots, not only in the lungs, but throughout the rest of the body. We've already been seeing patients with stroke-like symptoms, heart attacks, and injured kidney and liver function due to clotting factors that are happening with COVID virus. So a variety of mechanisms we've come to recognize and understand, and treatment strategies have been changing over the time now that we've better understood this process. So this is an extreme case of a young female in New York who ended up having COVID and was hospitalized and ventilated for many months, actually on a ventilator. She recovered in the sense of the virus was cleared out of her system. But on the right-hand side here, you can see this is the damaged lung that after her body fought off the virus, basically what was left over was scarred, fibrotic, injured lung, or both lungs actually, to the point that there's no way to actually ventilate this patient. Even as she was being ventilated through a machine, there was no way that they could actually get her off the machine. So ultimately, she was accepted for transplant, and this is what a normal, healthy lung is supposed to look like. And she was able to get a healthy lung transplant that was successfully able to come off the ventilator. So this is an extreme case of what COVID can do to the lungs. What we've seen is really more realistically has been this type of disease, but in patches, meaning certain areas of the lung. And in some cases, we will see whole lung damage, but for the majority of cases, it's more particular areas of the lung that are damaged. So what leads to worry, which is what are the long-term effects of COVID? And that's yet to be seen, but we're definitely keeping an eye on. So COVID therapies. As I mentioned before, there's a variety of different mechanisms that are happening once the body's infected with the virus. So clearly the first line therapy is going to be an antiviral in that early phase. If we can catch it early enough, we want to always get the antiviral therapies in the first 10 days of an infection. The tricky thing is patients may not show symptoms until a week after they've been infected. So really using antivirals later in the case have no role because the inflammation has already taken so much effect that likely the virus is already out of the system by the time damage is done. So it's all about timing on when to use antivirals, and remdesivir has been the drug of choice for currently at this time. Anti-inflammatory therapies, as I've already mentioned, a variety of different drugs have been postulated for therapy to use against the inflammatory, or against, if you would imagine, once again, using the analysis of the military, you're just trying to reduce the inflammatory cascade and damage that is doing to the alveolar sites. The best really to overcome all inflammatory system is steroids. We've looked at individual therapies that knock out one branch of the inflammatory cascade, or for example, one branch of the military cascade, but really to knock out the entire military, the nuclear option is steroids. Steroids really knocks out everything at high doses. The other thing we've been seeing is patients, particularly the ones who are becoming critical, hypoxic, transferring to the ICU, have been very depleted in vitamin D levels and also vitamin C levels. So we've been very aggressive in supplementing, and there's starting to develop a pretty significant amount of evidence that supports consideration of prophylactic use of vitamin C and vitamin D to help minimize or prevent the damage of COVID inflammation of the lungs. The next is antibody therapies. This has been thought up for a variety of other disease states in the past, historically, in the sense of if you had the virus or an infection of some sort and was able to survive it and did well, it's because your body developed antibodies and killed it off. So what we've been able to produce is essentially patients who've recovered from COVID can go to donate blood and donate, actually it's the plasma that we're looking for. And plasma donation, they are able to isolate antibodies, and that antibody plasma filled bag is then given to the next patient coming into the hospital who's acutely ill. And in that early phase that I was referring to in viral replication, if your body's never seen that virus before, your body doesn't have antibodies to fight it. So the thought being that if you transfuse plasma of somebody who's already recovered, you're giving that sick patient antibodies to help initiate the inflammation to help reduce viral replication. That is yet to be 100% proven successful yet, but it is approved by emergency use from the CDC to be given, and we're still waiting to see more data to see if that concept works or not. The final treatment category is anticoagulation. As we've already stated, definitely damage to the blood vessels have been noted, leading to blood clots in the lung, blood clots in the brain, and blood clots throughout the heart, kidneys, and lungs. So we're very aggressive in the hospital using anticoagulation for patients who are admitted with COVID. Outside the hospital, there's a good amount of data to suggest maybe low dose aspirin, but keep in mind every medication there's always risk and benefits with. So even a simple baby aspirin, 81 milligrams, for some patients can be a devastating bleeding complication. So you always want to discuss when you're talking about prophylactic regimens at home with your doctor as to whether it's safe for you based off your medical conditions to consider whether it's vitamin C, vitamin D, aspirin, or any of the other prophylactic regimens I'll explain here, or other things that you might hear on the street or on social media. Always, 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 I can't emphasize the point, discuss it with your doctor first before you consider taking any of these prophylactic regimens. So antiviral therapy, as I mentioned, remdesivir really being the mainstream, which is really the only approved antiviral regimen at this point. We have been in research activities using other trial drugs to consider for antiviral research, but the data has not been published yet as to whether this type of other antiviral medication will be successful or not. But this medication, remdesivir, which is currently being used, has been used for many years for HIV, has found to have some improvement in mortality when looking at patients with COVID therapy. That being said, want to emphasize the point, therapy or the trials that were noted, that mortality was really about a 4 to 5% improvement. So it wasn't a huge improvement. It wasn't a game changer in the sense of a cure to the disease, but clearly 4 or 5% is better than nothing. So when applied, we feel it is beneficial. But just to be clear, just because somebody's getting remdesivir or somebody wants to get remdesivir, it's not necessarily a cure to this disease. Anti-inflammatory medications. So as I mentioned before, steroids is really the end all of all if you really want to knock out the entire immune system. But like everything, it's a double-edged sword. So there's a lot of good with steroids or anti-inflammatory medications, but there's also a lot of bad that comes with immunosuppressive therapies. The good is you reduce inflammation, you reduce the damage to the lungs that the virus has initiated. The bad is the patients become in the hospital for a prolonged period of time. We've had an average COVID ICU patient stay on average about 4 to 6 weeks in the hospital. So those patients are exposed to a variety of other infections and organisms in the hospital and really throughout the community. So patients, as we're aggressively immunosuppressing them to reduce inflammation, now are very vulnerable to any common cold, any other bacteria, fungus, other viruses that could potentially be brought to them or they can become in contact with. So what we've unfortunately seen in patients who we've been aggressively trying to suppress their immune system, unfortunately the ones who have been hospitalized and placed on ventilators, 3 or 4 weeks down the road, we're dealing with secondary infections due to the aggressive immunosuppression. So to now, it's essentially the best approach that we have. We've been able to show reduce ICU critical courses with steroids, but it really truly isn't the end all of all. We really are continuing to work aggressively through our research trials to see what is going to be the best targeted approach. Now, monoclonal antibodies, you've probably already heard some on the news. Monoclonal antibodies is a laser-focused direct military approach to one particular aspect of the immune system, whereas steroids blocks everything. Monoclonal antibody, you're really trying to knock out one particular messenger or one particular cell or inflammatory cascade of this process. We're trying to knock out one specific thing. As you can imagine, there's been millions of dollars invested in this. Pharmaceutical industries have been trying aggressively to try to find which is the holy grail to stopping the damage due to COVID virus. But as many medications have been tried, a lot have been found to be unsuccessful, but some have already found to have some promising results. One particular, mavrilimumab, this one here, balinomumab, and everything that ends with a mab means monoclonal antibody. This was approved and given the FDA approval to use for outpatient use. The Regeneron also has been approved, have been successful, both of which have had interim analysis successful enough to proceed with emergency use authorization, but has not really sufficed the FDA for complete authorization in the sense of approval for a cure per se, I would say. But CDC and FDA have reviewed the initial analysis of these two agents and felt that it was safe enough, and the early studies show that they were beneficial enough to go ahead and proceed for national use. So we are implementing these medications as they become available. The other medications still are pending, but we're eagerly waiting to see what comes out. This next medication, CD24, we were one of the highest enrolling sites in the Baptist system nationwide. Interim analysis looks very promising, and we're waiting to hear back. FDA, this is currently being reviewed by the FDA right now, and we should hear back soon if they are going to approve it for emergency use authorization. The next medication, unfortunately, has not found to be very promising, and this medication has been closed out. Hydroxychloroquine, as you can all imagine, has had its ups and downs. We are not currently using hydroxychloroquine, but to the defense of hydroxychloroquine, it's been used for years for anti-inflammatory therapies. So the thought of using hydroxychloroquine from the surface makes sense because of the anti-inflammatory properties. It has to reduce inflammation. But unfortunately, as we did more as studies were done, and evidence-based medicine showed when they did a large group of patients with hydroxychloroquine, no significant signal or benefit was really noted. So the medication has been pulled from our trial treatment medications and is not being used in the Baptist system at this time. The VIP analog was considered, but has since did not show any positive analysis on the interim analysis, so that was then closed out. We're not using that drug anymore. This particular case, I thought was a great case to show. This was one of the trial drugs we were using. It's called linzulumab. This is one of our very first patients we had with COVID. He's a long-term patient of mine. I've been taking care of him for many years with COPD. Unfortunately, he had to travel down south for work-related events early March, April, came back and came down with fever, chills, and presented to the emergency room and found to have COVID positive. He admitted to the hospital, initially to the medical floor, but then rapidly progressed and needed ICU care. Fortunately, he did not require to be intubated. We were able, through high oxygen concentration, be able to avoid having to get intubated. But you can see on the left side of the slide, his chest x-ray. This is his right lung. This is his left lung. The upper lungs, this dark areas is actually emphysema. So he had predominant upper lobe emphysema in his upper lungs. And his lower lungs, all this whited out and inflammatory areas is where COVID essentially caused a lot of inflammatory changes. So he had upper lobe COPD emphysema changes and lower lobe COVID inflammation. So you can imagine how sick he was on the brink of many of days, almost get intubated. And we were able to skid through without really having to get him on life support. But as you can see, when he got admitted, this graph here shows how much oxygen and liter flow that he required. Naturally, we should not be using oxygen. So somebody healthy state really would be down here without oxygen. So as he was admitted to the hospital and required a significant amount of oxygen, we were up to 60 to 70 liters of oxygen flow. And over the time progressed over 4 months, he really had just a very kind of slow taper. And as you can imagine, being in the hospital for 4 months, the psychological effects, depression was setting in. He was starting to really doubt whether he was ever going to make it out. He was starting to question whether he wanted to continue. There was even discussions about whether he wanted to consider a hospice consultation. His mind was sharp, but his lungs couldn't come over the oxygen demand that it needed. But when this particular medication called linzulumab became available for a research trial, he was the first patient that we were actually able to get enrolled in the trial. As he got the medication, you can see almost immediately afterwards, his oxygen demand came down to the point where he was down to just regular 2 to 3 liters of oxygen and successfully discharged out of the hospital. And this is him right here as he's being discharged out of the hospital. He was one of our very first success patients, and the news did a little story on him. And he still, to this day, has been following up in the office, doing great. He still uses 2 to 3 liters of oxygen, but once again, it's just a great success story. Unfortunately, and mixed in with the unsuccessful stories that we've had, throughout the course of COVID. So,
Dr. Pulido,
I'm sorry?
we do have a couple questions if you want to take a question, or do you want to wait? Okay. Yeah, Josh Jolly asked, thinking of what happened to the UF basketball player Keontae Johnson, how common is myocarditis as a lasting side effect, and how long could it last?
Great question. So once again, going back to that inflammatory response that occurs, what I showed was really just the inflammation that happens in the lungs. But what we're seeing is this inflammatory cascade is really happening throughout the entire body. So certain areas or certain parts of the body are more vulnerable to inflammation than others. The heart being one specific, the myocarditis was started to be seen in the early months, March, April, May, June, in the pediatric world, not so much in the adult world, but they did have cases of pediatric induced cardiomyopathies. And fortunately, that has since come down in incidence. But we've seen stroke, a variety of patients admitted with brain injury due to COVID inflammation and clotting issues. We've seen kidney failure. We've seen liver injury. So although the lungs are definitely the primary organ of where the virus gets inoculated through and replicates and damages the most, but other parts of the body are definitely vulnerable. The question is, my suspicion, my professional opinion would be, whoever gets infected are likely going to have all organs inflamed to a certain degree, some more than others. It's just, in his condition, clearly they're very healthy athletes, playing at their extreme point of in their career or in the progression of their career. I don't know. I haven't taken care of him. I don't know if he's had an underlying condition prior to that he may or may not have been aware of. But definitely stressing an inflamed heart, I could see how it could increase the risk of a irregular heartbeat or an arrhythmia that led to his event that collapsed on the court. So ultimately, it clearly happens as we test in patients who are hospitalized in the ICU. We're testing blood levels of inflammatory numbers, and the inflammatory numbers for months remain elevated. Now, that once again is not just inflammation of the lungs. These are blood tests that are taken from veins. So that's really a marker of inflammation going throughout the entire body. So we're in that look. We're constantly looking for patterns, for profiles on how to predict. We've become very confident in predicting what comorbidities are associated with worse outcomes. But that's not to say things fall between the cracks and just things don't really add up. And unfortunately, we get these odd cases of people having odd injuries associated with COVID. Was there another question?
Yeah, one other question. When, in your opinion, did COVID first appear in our area, and how long are we seeing antibodies last, so to speak?
So that's a great question in the sense of when did it first appear. When we first started, when we finally had the test available, was really early mid-April. We started to see an increase in admissions for respiratory symptoms in March, but the test was not available at the time, although there was already talk about possible COVID the virus itself and how to kind of more or less expect some of that those patient populations coming over, or the virus itself. In talking to patients and talking to throughout the community, I've had a number of people come to me and say, I've had COVID-like symptoms, January and December. At that time there was no test available. Who's really to say whether it was here a couple months prior or not? I would say that we did not have an alarming spike of respiratory events in our ICU prior to March, April. Everything was kind of chugging along normally. Every winter we get our average spikes of influenza, RSV. Interestingly, we have been getting, prior to this pandemic, coronavirus infections. When patients admitted to the ICU pre-COVID for respiratory issues and are requiring oxygen higher than normal oxygen levels, we always do a respiratory panel, which is anywhere from 14 to 16 common viruses that we look for. Influenza being one of them, our respiratory syncytial virus, a lot of the common pediatric viruses. And in that panel, coronavirus is in that panel. And we commonly see, prior to COVID-19 pandemic, 2, 3, 4 coronaviruses positive on a yearly basis or on a winter basis. So the virus itself, or the family of virus itself, is not new to us, but this particular mutation clearly is. So I can't say for sure when the first patient came over to Jacksonville area, but definitely the uptick in admissions to the hospital was really more mid to late April. The second question was, how long do antibodies last? And dealing with the blood banks and blood alliances, to the ones who process the donated blood and plasma, what I've been told through the medical director of the blood bank is that they've been seeing antibodies in donated plasma last around 4 months. And how do they get to that? They have a huge population of patients that regularly donate. They only allow one donation per month, but there are a lot of patients who routinely go donate once a month. And they've isolated patients who had COVID antibodies and specifically monitored their antibodies as they continued to donate, and when the antibodies were detected, and then when they eventually fell off. And what they've said on average has been about 4 months that they were eventually the antibodies were no longer detected. The $1 million question, which I don't know if the answer is out yet, is how long is the vaccine protection going to last? And that is yet to be determined, whether it's lifelong, whether it's 6 months, whether it's yearly. We'll wait to see what the data shows. Monoclonal antibodies, really quick, not to make you guys experts on this, but really just to understand the concept of how we get to monoclonal antibodies. The target that we want to achieve, meaning an antibody to affect or to kill a virus, to kill a bacteria, or to kill a tumor cell. Monoclonal antibodies is really becoming an emergent therapy for a variety of disease states, and cancer being one of them. The monoclonal antibodies has been very helpful and instrumental in combating a majority of our oncology problems that we're dealing with on a day-to-day basis. So ultimately, whatever target you're trying to kill, activate, or deactivate, they essentially inject that target into a mice, and that mice will develop its own antibodies. Those antibodies are isolated, and once isolated in a lab, can then be replicated. Once replicated, can be removed, and then once isolated in its own treatment or its own substance, can then be packaged and processed to where it could be injected into a patient. So that's how the concept of targeted therapy to one particular agent, virus, bacteria, tumor cell, whatever it is we want to target, that's how the process is made in the lab. Supportive therapies. So as I mentioned, we've seen a variety of patients in the ICU who are admitted end up having very low, critically low vitamin D levels. Now, whether that is directly due to patients being, in isolation and being more kind of indoor and avoiding crowds, or whether there's a nutritional component to that, but we've been very aggressive in patients who are admitted to the hospital and supplementing vitamin C, vitamin D. We have been giving zinc. Melatonin is also another one. So the thought on melatonin is that our immune system, when we sleep, well, there's 4 stages of sleep. Stage 1 and stage 2 is our light sleep stage, where you're asleep, but if somebody's in the room, you kind of hear something, you kind of wake up quickly, and you know somebody's there, or you wake up quite easily. Stage 3 and stage 4 are more of a deep sleep. Stage 3, you're kind of more of a trance sleep that it's hard to arouse, but you can be aroused if somebody stimulates you enough in the sense of waking you. Stage 4 is your REM sleep, where you're almost in a paralyzed state, where your body is in deep, deep sleep. Stage 4 REM sleep is really when your body is recuperating the most, when your proteins are when your immune system is recuperating and your immune system is gathering in the hematopoietic part of the body, which is the liver, bone marrow, is really being the most active and regenerating all the antibodies and all of the military aspects of what I was mentioning before when in regard to the immune system. So as you can imagine, patients who either have COVID or fear of having COVID, the anxiety it causes at nighttime, at bed, unable to sleep, being stuck to the phone, having TV on, whatever it is that they're getting poor quality sleep, those patients are run down, their immune system's getting weak, and they're ultimately, if they get the infection, have very little to response to this virus, and the virus continues to replicate in their system. So we feel a good sleep hygiene is very important. So melatonin we've implemented to everybody admitted to the hospital. In addition to, it's just hard to get good sleep in the hospital with, obviously you can imagine the nurses going in and out, the alarms buzzing, and all the activity that's happening in the hallways. Sleep in the hospital is nearly impossible. Antibodies, as I mentioned with the convalescent plasma, is essentially plasma given from a donator, from a patient donating who has antibodies already in their system, packaged into a plasma bag, and then given to new patients who come in with acute viral infection, who are in that first early phase where their body doesn't recognize the virus yet and doesn't have antibodies to kill it. So this has been shown. There was one study that showed it had some effect, and then unfortunately a subsequent study showed that there was no effect. So then really CDC and FDA has taken kind of a neutral stance, and they say, well, we don't feel it hurts, but we don't really have 100% proof that it really helps, but we'll give you the opportunity to at least use it if you want to consider using it. So we are still offering it to patients, and if they don't have any reasons to refuse blood products, because this is a blood product, there are religious reasons people don't want blood products, but if they're okay with receiving a blood product, we'll offer this option, and they are able to get it. So the anticoagulation being the last part is really the treatment of choice has been Lovenox. I know there's a variety of other anticoagulation therapies out in the community. A lot of patients take Eliquis, Xarelto, Pradaxa, Coumadin. Really, the studies have shown that Lovenox or heparin are really the ideal therapies for COVID-induced thrombosis. So in the hospital setting, if somebody comes in on Eliquis or Pradaxa or Coumadin, we actually switch them over to Lovenox or heparin, because that has been found to be actually superior when dealing with COVID-related thrombosis. That being said, as the patients who we now know, we know they have at risk of thrombosis, we also have realized that they're also at risk of bleeding. So it really puts us in a difficult situation when treating these patients. We initially were giving high-dose Lovenox, full what's called 1 mg per kg dosing, but we have found with that strategy, a lot of patients were having internal abdominal bleeding problems that were fatal. So we backed off with the high-dose Lovenox therapy and have maintained a moderate Lovenox regimen to make sure that the bleeding complications have been minimized. And with that regimen, we've yet to have any bleeding complications. So we've become more confident in that regimen. But once out into the community, it's hard to say what's the best approach. Clearly, you're not going to get Lovenox and heparin out in the community, but still, we feel that some anticoagulation is probably better than none. And if you have an indication to be on anticoagulation, great. We're not initiating anticoagulation therapy for the community-based patients just because they have COVID. But once again, the question of whether a baby aspirin, 81 milligrams, may be a benefit. If you don't have any risk factors for bleeding, it would be something to consider in discussing with your primary care doctor. The home recommendations, if you get COVID or if you have a family member or friend that has COVID, this is essentially the recommendation that we're providing to our patients. Vitamin C, essentially, and this can also be used as a prophylactic regimen if you feel you've been in contact with somebody who's had COVID. I don't recommend everybody taking this every day for the entire year, because we know long-term effects of any vitamin supplementation can unfortunately cause kidney injury and other parts of the digestive and liver tract that we don't want to overdo. So, but this would be something that you would consider using if either you've been in contact with somebody with COVID, or you actually get diagnosed with COVID. So vitamin C, 2,000 milligrams daily. Vitamin D, 2,000 units daily. Melatonin, 3 to 6 milligrams at night. Zinc, just the over-the-counter is good enough. You don't need prescription strength of zinc. And then once again, aspirin if you have no risk factors for bleeding. Highly recommend nowadays. Oximeter now is very cost effective. They used to be $80, $90, $100. Now on Amazon, you can get them for about 12 bucks. So this is a great, simple mechanism to determine oxygen levels in your blood. And as I said early in the presentation, 75% of the patients will have no problems and recover on their own at home without ever needing to go to a doctor. But 25% of the patients will need to come to the hospital. And the differentiator between who comes to the hospital and who goes home in the emergency room is oxygen levels. So if your oxygen level, which is this SpO2 on an oximeter, is less than 90 or 92, that's when we admit to the hospital. This other number is the heart rate. But once again, the most important thing is being the oxygen level. So if you have an oximeter at home and you can monitor your oxygen levels, despite feeling icky, despite having fevers, despite feeling the body aches, as long as your oxygen levels are fine, you can comfortably stay home and continue to recover. You don't need to be going to the emergency room and being exposed to other people coughing and have other infections around you, as long as your oxygen levels are good. The most important thing I can't emphasize enough, for a variety of reasons, is getting out and getting fresh air and walking. The psychological effects that COVID has had to our community and nationwide of being locked down has been so detrimental in our ICU. We've actually seen, I think it's probably safe to say anecdotally, I've probably had more patients in the ICU on ventilators in the past 2-3 months due to alcohol abuse than I've had due to COVID. I've seen more suicides, more overdose, more elderly neglect in this past 6 months than I've ever seen in my entire career. So I can't emphasize enough the importance of getting out, walking, just clearing your mind, getting out of the house type scenario. Clearly doing a safe walk, not in big crowds. Being out in the beach area, there's an advantage of walking on the beach, but clearly if you're in town, walking along the river or something of that nature, I can't emphasize the importance of how that helps psychologically and helps promote respiratory exercise pulmonary wise. That helps mobilize secretions. It improves the respiratory capacity to really optimize your lung function and just overall general health. This just really quick, the last slide is just what we've seen with the vaccines, Johnson & Johnson, Pfizer, AstraZeneca, Moderna. Currently what's being utilized here in our community, Pfizer and Moderna are what has been vaccinated through both the health department and at least through Baptist system. We have both Pfizer and Moderna currently being given through the Baptist employees. Johnson & Johnson, if I'm not mistaken, I believe was just recently approved, and I'm waiting to hear back on what's happening with the AstraZeneca one. But I get asked all the time, should I get the vaccine? And the reality is nobody knows. I mean, clearly we're in a crisis pandemic situation, and clearly in the history of medicine, there have been major errors with drug developments, but there's also been tremendous success with drug and vaccine developments. So, two best examples, the anthrax vaccine that was given to military, that they thought it was helped to prevent military personnel as they traveled throughout the world to minimize infections with anthrax, came back and had their offspring's children had birth defects due to the vaccine. But at the same time, penicillin, aspirin, all these medications were thought to be toxic when they first developed, and they thought they'd harm people. And look how they're saving lives because of the simple antibiotic of penicillin or a simple medication like aspirin. So clearly, a lot of what we learn, a lot of what we develop is best understood over time. You just have to make the best decision with the information you have at this given moment. At this given moment, my personal professional opinion is I think it is safe enough to consider the vaccination. I recognize that it was these vaccines were produced in a very short period of time. but also recognize technology has advanced to allow us to be able to do stuff in a much faster time frame, as I showed with the monoclonal antibodies. That 10, 15 years ago was unheard of, and now we're doing that to treat cancer. So medicine technology has drastically advanced to warrant this type of process and procedures to be done in such a short period of time. And with that, I wrap it up. Thank you very much. For any questions.
Thank you very much, Dr. Pulido. That was obviously very informative, a lot of very interesting information. I wanted to thank you for coming on and sharing your time with us. I'm going to skip the networking just because there was a lot of information. There's a couple questions, so I realize if people have to drop off, it is a little bit after 1, so feel free to do that. But one question that I wanted to ask that was asked in the chat is, how common is it to get COVID a second time, and then are they giving the vaccine to people who have had COVID already? And if you'll answer that, then I'll let you get back to what I'm sure is a very busy schedule for you.
Yep. So I have heard of cases being of patients who've actually had COVID twice. So that it can happen, especially since we are recognizing that immune systems or antibodies really give us about 4 to 6 month protection. Regarding can you get the vaccine after having COVID? Theoretically, you can. I just recommend, so my personal experience, I had COVID last month and a half ago, and I was already signed up to get the vaccine as being in the ICU. We were one of the first to get it. I was dreading whether or not, in my mind internally, whether to get it or not. Given the fact that I was still fighting the symptoms of COVID, from the Pfizer recommendation package, it said not to get the vaccine if you have COVID or if you have symptoms. My test for COVID came back negative the week prior to my scheduled vaccine date. My symptoms did resolve the few days prior to the vaccine date. I got the vaccine thinking that I should be safe, but that day after the vaccine was administered, about 12 hours later, I started to have COVID-like symptoms again of body aches, fever, chills. Lasted throughout the night, but the next morning I woke up feeling fine. So then talking more and more to doctors, nurses who got the vaccine, it sounds like patients who did have COVID virus, who they knew they had it, who got the vaccine were having similar descriptions of what I had in the sense of over-exaggerated response to the vaccine. And patients who, or colleagues and other coworkers who never had COVID, who got the vaccine felt fine the next day. Now, once again, we've always known with any kind of vaccination, you can get what's called a serum sickness, which is a reaction to the vaccine, that's what you're actually trying to provoke, is your immune system reacting to it. But that was naturally just a serum sickness reaction. It wasn't that I actually got the virus all over again or infected again.
Well, thank you very much. Again, very, very informative, a lot of obviously timely information, and thank you for coming and sharing with us today. I will say that we will have our next meeting on February 4th. So look forward to seeing you all again, even though it may be virtually. And again, thank you to Dr. Pulido for coming on and sharing your time with us today.
A pleasure.
Thank you.